A 7-year-old boy is brought to the emergency department due to marked respiratory distress. He has had nasal congestion for the past 6 days and developed fever, chills, and productive cough over the last 48 hours. He was diagnosed with cystic fibrosis through newborn screening and has required multiple hospital admissions since early childhood for lower respiratory tract infections treated with intravenous antibiotics. Over the past 12 months, he has also experienced recurrent skin abscesses requiring incision and drainage. On presentation, his temperature is 39.2 degrees Celsius or 102.6 degrees Fahrenheit, blood pressure is 92/58 millimeters of mercury, heart rate is 128 per minute, and respiratory rate is 34 per minute. Pulse oximetry demonstrates an oxygen saturation of 86% on room air, improving to 93% with supplemental oxygen. Physical examination reveals nasal flaring, intercostal retractions, and grunting, and lung auscultation is notable for bilateral basilar crackles with expiratory wheezes. Chest radiography shows bilateral lower lobe infiltrates. Rapid influenza testing is positive. The patient is started on cefepime and oseltamivir. Which of the following empiric antibiotics should also be administered? A. Intravenous itraconazole. B. Intravenous nafcillin. C. Intravenous vancomycin. D. Oral amoxicillin. E. Oral azithromycin. Or F. Oral ciprofloxacin. C. Intravenous vancomycin. Pulmonary complications are the leading cause of morbidity and mortality in patients with cystic fibrosis. Impaired mucociliary clearance leads to retention of thick secretions, promoting recurrent sinopulmonary infections. This patient is experiencing a severe acute pulmonary exacerbation, as evidenced by hypoxemia and significant respiratory distress. In young children with cystic fibrosis, Staphylococcus aureus is the most frequent bacterial pathogen, particularly in the setting of concurrent influenza infection. Patients with severe pneumonia require prompt intravenous empiric therapy targeting staphylococcal species. Although cefepime provides coverage for methicillin-sensitive S. aureus, or MSSA, and Pseudomonas aeruginosa, this patient's history of recurrent hospitalizations, recurrent skin infections, and influenza infection increases the likelihood of methicillin-resistant S. aureus, or MRSA. Therefore, intravenous vancomycin should be added to the empiric regimen. Now, briefly reviewing the other answer choices. Choice A, itraconazole and voriconazole are antifungal agents used to treat chronic pulmonary aspergillosis. Although Aspergillus fumigatus colonization is common in older patients with CF, invasive fungal disease is uncommon in younger children. Choice B, nafcillin is effective against MSSA and Streptococcus pneumoniae. However, because cefepime already covers MSSA, nafcillin would not expand antimicrobial coverage to include methicillin-resistant organisms. Choice D, high-dose oral amoxicillin, is used for outpatient treatment of community-acquired pneumonia, primarily targeting S. pneumoniae, and does not provide adequate coverage for S. aureus. Choice E, azithromycin, is typically used for atypical pneumonia pathogens such as Mycoplasma pneumoniae. In CF, it is used for chronic anti-inflammatory maintenance therapy, not for acute exacerbations. Choice F, ciprofloxacin, is active against P. aeruginosa, which is more commonly implicated in adult CF patients. Additionally, oral therapy is inappropriate in this patient with severe pneumonia. In summary, in young children with cystic fibrosis, Staphylococcus aureus is the most common cause of bacterial pneumonia, especially when influenza infection is present. In patients with severe disease, frequent hospitalizations, or recurrent skin infections, intravenous vancomycin should be included for empiric coverage of methicillin-resistant S. aureus. Thanks for studying with me. See you in the next video.